Hi everybody, I'm Professor Agi Abdedaim, cardiologist and electrophysiologist at the Military Hospital of Tunis and the Cartagena Clinic of Tunis. I want to share this case with the community of cardiologists and discuss how a 3D mapping system can improve the management of relatively simple arrhythmia as WPW syndrome. This is the case of a 14 years old teenager who has been followed for 2 years for symptomatic Wolff Parkinson-White syndrome, and she suffered from several attacks of palpitation. She was put on antiarrhythmic drugs with an association with flecainide and beta blocker. She was admitted several times to emergency room for fast tachycardia, for which she receives amiodarone and sometimes external electrical shocks. She was referred to our electrophysiology cath lab for a catheter ablation. This is her 12 leads ECG that shows a WPW syndrome pattern with a normal axis and an LBB pattern indicating right location of the accessory pathway. Some of our colleagues thought that may be a paraseptal accessory pathway and there is a serious risk of AV block, and in consequence we should avoid catheter ablation. But given the very symptomatic character of the arrhythmia, after a thorough discussion with her parents, they finally accepted the procedure of ablation. We have done our first procedure on 21 November 2022 under general anesthesia and with the use of non-irrigated and also an irrigated tip catheter. We were able to locate the accessory pathway at the level of the inferior and lateral walls of the tricuspid annulus. So we delivered several shots of radiofrequency at the presumed site of the accessory pathway, but without effectiveness. So she was discharged, maintaining the same antiarrhythmic treatment. A few days later, she returned to the emergency department for several episodes of prolonged tachycardia with chest pain and shortness of breath. So we decided to redo a new procedure, but this time with a 3D mapping using G&G Carto 3 system. We started the procedure on 15 December 2022 at 6 p.m., of course, under general anesthesia. Tachycardia was easily inducible, and therefore we were able to perform a retrograde activation map to identify the earliest atrial activation. And as you can see here, the accessory pathway was at the level of the right inferior lateral wall of the tricuspid annulus, the same sign found at the procedure before. Here. We applied the first shot on the AV fusion site on the tricuspid annulus, but it was ineffective. So we moved the catheter slightly toward the marker mentioned by our friend Mustafa Nawar, our technical support, and it was enough to apply a few seconds to stop the tachycardia and block the accessory pathway. We applied, of course, more additional shots to consolidate the result and to get a good result later, as you can see here. Now, this is her ECG post-ablation. So I want to thank our this system mapping and which help us to achieve this ablation with a major advantage in precision and efficiency. I take this opportunity to thank you, my friends, anesthetists, nurse, technician, who contribute to the success of this procedure, with a special mention to Mustafa Nawar, our technical support. I think that this case was benefit for you. Thank you for your attention.